Alright guys, so today I'm going to be discussing the pericardial sac and the associated disorders that the patient can develop. So generally speaking, the pericardial sac has two sides to it, okay? It's got the side that's touching this side right here, that's touching the actual heart, the viscera, the organ. So we call that the visceral pericardium. And then you have the part that's on the outside, which is touching the lung, because the lung would be on this side, and that's called the parietal pericardium. And so the whole purpose of this pericardial sac is, with the fluid that's encased inside, is to provide lubrication. So every time the patient breathes in and the lungs expands, it squeezes the heart, but there's lubrication. It glides effortlessly, so there won't be any friction. We discussed pleurisy and pleural effusion and pleural friction rub in the previous video that discussed respiratory disorders. However, now we're going to be discussing the sac. Now, this sac, the pericardial sac, I'm going to write it up here. The pericardial sac provides the same function as the pleura does, but instead of for the lungs, it provides it for the heart. And that allows the heart to pump effectively without any extra pressure or resistance being placed on it. Now, this pleural sac can be infected by a variety of microorganisms, or even sometimes azotemia. Azotemia is a condition where you have excessive metabolic waste, excessive nitrogenous waste, and that seeps inside the fluid, the serous fluid of the pericardial sac, and it tends to irritate it. And also, when a patient has an MI, a myocardial infarction, the MI that occurs will prevent the fluid from being created adequately, and it's going to start irritating the pericardial sac as well. So all of those elements can contribute to the disorder that I'm going to be discussing tonight. And so the disorder is going to be pericarditis. And so pericarditis occurs when the membrane around the heart is inflamed. And again, it can be inflamed, it can be caused to inflame by a variety of elements, including azotemia, including a pathogen, and including an MI. It could be secondary to an MI. So that's important for you guys to understand, because after a patient has an MI, that can lead to pericardial friction rub, which is going to be caused by pericarditis, irritation of that membrane where the infarct occurred underneath in the actual myocardium. So when you have pericarditis, now every time the heart is pumping, now there's going to be some degree of discomfort, because the membrane itself, which is supposed to reduce friction and provide lubrication, that's not happening anymore. So keep in mind that we discussed distinguishing your pleural friction rub from pericardial friction rub. And as the heart beats, thump, 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 you have the patient hold their breath. And if you can still hear the friction rub while the patient is not breathing, while the patient is apneic, well then that means that your heart is responsible for that friction rub. But if it only occurs when the patient's breathing in and out, and exclusively when the patient's breathing in and out, then that's going to be your pleural friction rub. So make sure you guys are able to distinguish the two. Now, this pericarditis is going to cause a lot of irritation. It's going to also potentially cause aggravated inspiratory pain. As the patient breathes in, it squeezes that heart a little bit more. Now, when the entire membrane becomes inflamed, that will lead to something called pericardial effusion. Okay? And now the entire membrane is inflamed. The patient's going to have systemic effects of inflammation, of infection. However, that's not going to be the issue that's going to really potentiate problems for this patient. Once the once the fluid is inflamed and the membrane becomes more and more irritated, this can lead to a serious condition known as cardiac tamponade. And cardiac tamponade is a whole other monster in itself, because the sac that surrounds the heart, the pericardial sac, becomes accumulated with an excessive amount of fluid. And this fluid restricts the heart pumping capability. So I'm going to show you guys real quick what that would look like. That membrane, and again, it doesn't just happen in this exclusive area that I'm illustrating. It happens around the entire heart. But if you can imagine, the pericardial sac is now filled with fluid, and that fluid is creating pressure against the actual heart. And this creates a problem because the heart is supposed to be able to pump effortlessly without any restrictions behind it. If you have outside restrictions, now the cardiac output is going to be compromised. Now the cardiac workload is going to be increased. The heart has to work harder now to effectively create the cardiac output, to perfuse blood away from the heart so it can perfuse all the tissues, including the distal parts of the brain and the lower extremities and everything in between. Because of that, you're going to have some specific signs and symptoms. When it comes to your clinical manifestations of cardiac tamponade, and I'll write it down here so you guys can remember. Cardiac tamponade, okay? When it comes to these basic signs and symptoms, the patient's gonna have an abnormality in their blood pressure. And this is gonna be known as, pulsus paradoxus. And pulsus paradoxus is when you have a low blood pressure that's typically lower than the patient's normal baseline. Now, this happens because every time the heart recoils and contracts, it pushes blood through the aorta, and eventually through our systemic circulation, we check our blood pressure, and it's supposed to be around what? 120/80, correct? Well, in this particular case, when you have all this fluid surrounding the heart in its sac, it's not allowing the heart to recoil and contract efficiently, meaning that the chambers, the ventricles, the right and left ventricles, are not getting filled with the adequate amount of blood. Your preload, the amount of fluid that's entering the chambers, and it becomes affected. And so your heart's ability to push out the fluid is also restricted now because it cannot gather that enough force so it can push the fluid out, the blood out. And so this phenomenon of low blood pressure is known as pulsus paradoxus. The patient may also develop syncope. Now this is fainting. The patient may have an issue with perfusion to the brain, and they may pass out because of the inability to perfuse blood adequately throughout the system. The cardiac output actually decreases. And you'll also notice that the book discusses differences in the EKG rhythms. Now, generally speaking, you have P, QRS, T, right? What ends up happening with the QRS complex is that because of this limitation in the contractility of the heart, you're gonna have competing QRS waves. What that means is that you'll have your P, and you'll have your QRS and your T, and then your next P, your QRS might be a little bit lower than the previous complex. And you'll have the whole strip full of those type of abnormalities, meaning you'll have QRS that's big, QRS is small, small, and then big again. And this is what's gonna be happening to your EKGs, simply because the restriction of the heart, because of the accumulated fluid outside in the pericardial sac, is disturbing the electrical impulses that are passing through from the SA node to the AV node. And this is all going to be part of your data collection. Now, continuing with understanding that the heart's cardiac output is diminished, the patient's probably going to have cold extremities. The patient is probably going to have weaker pulses distally from the center core of the body. And this is all part of your nurse's data collection. Okay? Keep in mind that this type of condition requires medical intervention, something that we call pericardial centesis. And the pericardial centesis is a procedure where the doctor gets his needle, has his or her syringe, and they insert a needle into the actual sac, and they aspirate all the fluid that's causing the restriction to the actual heart. And this is something that you have to be very observant about, because your job as a nurse is to assess the pre and the post procedures, your assessments before and after the procedure. So while the patient has the cardiac tamponade, when you auscultate, your heart sounds are going to sound muffled. So keep in mind that you're going to have muffled heartbeats. Okay? But after the pericardial centesis, you're supposed to be able to have a more clear auscultation of the beat of the heart, and that's going to provide a lack of muffled heartbeat. So keep in mind that you want to do your pre-procedure assessment, You're going to be expecting muffled heartbeats. And after, how do we know that this therapy of the pericardial centesis worked? Well, you should be able to hear the heart more efficiently. And this, folks, is what happens in pericarditis all the way down to cardiac tamponade. I hope it made sense, guys. Please follow me on Learn NCLEX Now on YouTube and all my other social medias. Thank you.